Bismillahirrahmanirrahim. Now we move towards an important topic known preterm labor. Preterm labor is defined as irregular contractions of the uterus resulting in changes in the cervix that starts before reaching term. So now before discussing that, we need to know that what is normal term. Normal term is the date in which normal pregnancy occurs, as in normal birthing process takes place, in which all of the organs are formed and the baby is fully developed and nutritionally okay, and it's time for the mother to conceive that baby. So that is term, and term pregnancy occurs between 34 to 37 weeks. Now if a mother is 9 months pregnant, so the term would be around 34 to 37 week. Okay, so there are a lot of contractions during such pregnancy, also known as false contractions, such as Braxton contractions. Now, Braxton contractions are irregular contractions. In this, what the mother perceives is that the baby is coming, but and the uterus is contracting, but that only lasts for a few seconds and similarly disappears. But if these contractions become regular and they are associated with changes in the cervix, that means that is a danger sign actually. So this means that the baby is ready to come out, and if the baby comes out before 34 weeks, this is known as preterm. Now the changes in the cervix that occur that takes place is known as effacement. Now effacement is a condition in which there is thinning of the cervix, and later stages what happens is that the cervix starts to dilate. When the cervix starts to dilate, that is actually the mother is entering the first stage of labor. So if all of these things takes place before the 34 weeks, this is known as preterm. Preterm is further divided into 3 gestational periods: mild preterm, which is around 32 to 36 weeks; very preterm is 28 to 31 weeks. Now this is somewhat a dangerous period, because in this the lungs have not fully developed, you can say. So the mother needs approximately steroid for about 48 hours in order to mature these lungs before the baby comes out. So whenever the mother enters such a state, we mostly give steroids in order to overcome such a problem. But in extreme preterm labor, which is around 24 to 27 weeks, now in this period we cannot save the baby. Actually, we can never save the baby, because most of the organs have not been fully developed or underdeveloped, and the baby is not viable in such a period. As in, it's alive, but it cannot be humanly adaptive to such an environment. So in normal cases, this is known as very late miscarriage. Now, what could be the possible causes that could lead to such a problem? Now, this includes the vascular, abnormal uterine cavity, overdistension, along with infections and cervical weakness. Now, what's the vascular problem? Now, you can say that the baby is attached by an umbilical cord, the placenta, to the mother. Now the basic connection between the mother and the baby is this placenta. So if there is any disruption in this interface, so this would result in bleeding. Now bleeding produces irritation, and this irritation results in contraction, as been illustrated in this picture. Now other probable causes are abnormal uterine cavity. Then these probable causes could be uterine congenital malformation, or it could be cervical weakness, that the mother is not able to hold the baby, and similarly protrudes out. Abnormal placentation, and could be lowly light placenta, or other causes, or low position of fibroids. Then the other causes include overdistension, in which there is multiple gestation; polyhydramnia, in which amniotic fluid is in greater concentration, and this would result in overstretching of the myometrium, which is the middle layer of the uterus. Now because of this stretch, myometrium is a muscle, so whenever a muscle is being stretched, it would obviously contract. So this would result in effacement. Effacement, as I already told you, is the thinning of the cervix. So our next possible cause include infection. Now how infection elicit contraction? Amniotic fluid and whenever bacteria sends up, this is most commonly in female because because there is the pathway towards this area is quite short, as in the cervix is quite short, the distance is quite short, so bacteria can easily climb upwards. Now what they do, they cause inflammation would result in increase in prostaglandins, which would elicit contractions. Similarly, this would also result in neonatal rupture, neonatal sepsis, and chorioamnitis. Now the other thing is if the cervix is weak. Now cervix is like a band which is at the end of the uterus, which is holding everything in. So if due to any cause such as previous surgical damage, congenital defect, or any cervical shortening, cervical incompetence, or vaginal pathologies, this would not hold the amniotic sac in. Due to its weakness, the amniotic sac would rupture anytime and would be resulting in preterm delivery. Now, surgical procedure also results in preterm delivery, such as cholelithiasis of pregnancy, in which there is a lot of inflammation going on in the body, amniocentesis, if the mother wants to do a test on the baby and it is an invasive test, so obviously there will be ultrasound guided injection in order to know some sort of defect. This also results in preterm labor or any subsequent pregnancy loss. Now, what will be the clinical features of such a mother? In preterm labor, the patient will come to you with history of vaginal discharge, pelvic pressure, lower back pain. Okay, now in this preterm there is no rupture of amniotic sac, so she will only come to you with vaginal discharge, pelvic pressure, and lower backache. This may seem common complaints of a pregnant woman, but you need to assess it whenever such a patient comes to you with this. You start by doing the last menstrual period, assessing the last menstrual period. By that you can calculate the EDD, and you do an ultrasound examination, that what's going on, if there is effacement, if the baby's head is in the vortex position, and etc. Now then in normal examination you always start from the basics. Now in the basics you take the pulse, the temperature, hydration level, BP. You do an abdominal examination. In case of chorioamnitis, there will be uterine tenderness, and it would be the same thing. Tenderness would also be seen in placental abruption. So when these two things are clear, you need to do a speculum examination in order to confirm that there is a lot of fluid present in the vagina. This could be clear fluid, that would be from the notice that the amniotic sac has not yet ruptured, so the pooling of the fluid could be caused due to other things, and you need to affirm that there is blood or not. Okay, then the next is visual assessment. In visual assessment, you need to confirm that there is cervical dilation or not. Now, this is very diagnostic, and this will help you to determine that the baby is about to come out or not, and this is preterm or not. But always remember, digital examination should never be done, because whenever you put your digits in there will be prostaglandin release and it will result in spontaneous delivery. So always be concerned about this. Then the next is investigation. Now, investigation, the bedside test, which is the most important thing. This is the rapid assessment and used for diagnosis. Now, fibronectin is a protein that binds the chorier decidua membrane. So this is the connection between the mother and the placenta. So if you find this protein in that fluid, you know that there is something wrong and the baby is about to be delivered. There is placental abruption or something but similar to it. Now the next thing is you need to see is cervical length. Now on a normal transvaginal examination, the normal cervical length is about 35 millimeters, but due to effacement the size would reduce. So effacement clearly indicates that the labor process has been initiated. You can see dilation as well as funneling, and you need to do a vaginal exam every 1 to 4 hours in order to know that when the cervix is fully dilated and when the active amount of contractions occur, then you'll able to know that when the baby is finally able to come out. Okay, now next is preterm delivery with rupture of membranes. Now this is known as PROM. This is not that PROM. This is a quite difficult condition which you've mostly seen in movies, that my water broke. It's just like that. There is a lot of gush of fluid, but first you need to rule out that it is amniotic fluid or it is urine, because in female, because of increased amount of pressure due to the huge baby, there is a lot of pressure on the bladder, so it can result in urinary incontinence. So first you need to rule that it is urine or amniotic fluid. Okay, we'll again start with a baseline examination, which you'll do general stuff, then you'll do an abdominal examination. Now if she had excreted out so much fluid, you'll be able to feel the fetal parts more due to oligohydramnion. Oligohydramnion is a condition in which the amniotic fluid volume has decreased, and fetal parts are more easily palpable and seem more hard, and you can also see tenderness due to chorioamnionitis. Now in this, what you need, best easy examination is you put the patient in a supine position for about 20 to 30 minutes. Now you can see, after doing this, you can see immediately the left fluid will be coming out. So there's a clear-cut diagnosis for you that the membranes have ruptured. And again, you'd have to avoid any digital examination. Now, to confirm that this is amniotic fluid, we do a nitrazine test. So amniotic fluid is alkaline in nature, whereas vagina is acidic. So whenever we take a sample, now that stick would turn purple. So actually that stick would turn black due to amniotic fluid. So we can clearly know that the labor has occurred. So many times it would give you a false positive results in case of blood, semen and urine. So what you need to do is you need to again make a good diagnosis by checking the fetal well-being for tachycardia, and doing an ultrasound to visualize the amniotic fluid correctly, and do an amniocentesis to avoid doing amniocentesis actually. Now we also need to know about the cause. So we do a genital swab to rule out group B streptococcus infections, and we also see the maternal signs in which in such a condition there will be increased blood pressure and temperature, and the WBC will be indicating that there is proper infection. Now what happens in late miscarriage? If the mother is pregnant but around 17 to 23 weeks, she faces such regular contractions and such fluid coming out, there will be history of sudden increase in uterine contraction, there will be bleeding, abdominal discomfort, and mucosal discharge and backache. So by such a history, you know that late miscarriage has occurred. Now what do we need to do in examination? We need to do is we use a handheld Doppler and we auscultate the fetal heart. And then we do a speculum examination and visualize the cervical dilation with membranes bulging out from the external os. Now we have done all this, we need to confirm this. We need to do a nitrazine test, we do a fibronectin test, we do check for the cervical length, maternal well-being, fetal well-being, genital swab, and amniocentesis. Now in this, what happens is the baby is not viable. It cannot survive the new environment because it has not fully developed to that capacity. So hence there will be stillbirth in such cases. Now what is the management of such cases? In asymptomatic women, whenever female come to you with such discharge and such findings, but there is no positive finding on investigation or an examination, what we do is we again do a dating scan. We rule out any infections by doing a genital swab. We confirm this by taking bedside fibronectin tests. We check for prostagenal agents, and we advise the patient with lifestyle modification, do a cervical ultrasound if effacement has occurred or not, and the most important things, in order to overcome future problems, we do a cervical circlage. Now this is basically tying your cervix in a circular pattern, so in order to inhibit the patient becoming symptomatic. Okay, now this thing, what happens is we basically suture the cervix, so this will prolong the amount of weeks for the mother and till the time actual term is achieved. At that point we again untie it and wait for the normal delivery. Now in symptomatic women who have active discharge or gush of fluid, we need to have active communication and support between the doctor and the mother, so she should know what's going on and what outcome would be present or not. Now the next thing is we give the maternal steroids. Now as I've discussed, the fetal lungs mature at term, not pretermly, so we need to give her steroids for 48 hours in order to quickly mature these lungs. And if the fetus is delivered before such a case, this steroids is of no use before 24 weeks, because at that time there are other things going on and the lungs do not simply mature in that period. Now the next thing we can give tocolytics, which is inhibition of prostaglandins. Now what this does is this acts on the myometrium and relaxes the smooth muscle. The common example for this is rotadine, and this effectiveness of this drug is only for 2 days. In these 2 days you can combine it with a steroid and hence prevent future mishaps. The next thing we give with the patient is oxytocin antagonist. Now when there is contraction of the uterus, a hormone is released by the posterior pituitary, which acts upon this uterus again and provides further contraction. So we give the patient etoposide in order to prevent such uterine contraction. And prostaglandin antagonists such as indomethacin, we can also give antibiotics to prevent chorioamnionitis such as erythromycin, and emergency cervical circulation can also be done, but this is contraindicated in pervaginal bleeding, active contractions, and even in infections. Now if the above treatment in the symptomatic women has no effect, we simply induce the labor rather than inhibiting it. We give the patient oxytocin infusion. Before 24 weeks we give the patient Encytotec. After 24 weeks we give the patient Cervidil and normal oxytocin dose, and we plan for delivery. In late miscarriage we know that there will be no survival of the baby, so we simply do a vaginal delivery, as the baby size is very small and can be easily delivered through the cervix in less than 26 weeks. But in early miscarriage, as far is not developed yet, so what we do is we do a classical uterine incision, in which what we do is we open the abdomen and we give an incision in a longitudinal fashion over the uterus. This is also known as classical uterine incision, and we deliver the baby in early miscarriage. Now lastly, what we can do is we can assess the fetus by an ultrasound, and we can give the patient analgesics to reduce the pain, and in utero transfer in inviable units.